So I'm Rebecca Stack, and I know most of you know me, but I certainly see there's some slightly unfamiliar faces in the room. So I'm a cataract and oculoplastic surgeon here. I really appreciate any feedback as we go along with my talk. So if you've got any questions, put your hand up. If you've got any advice for me for any of the patients that I'm going to present, that would be much appreciated. If you've seen similar kinds of patients, you can also feel free to say, yeah, I've got one or two of those. I was saying to some people earlier that I think I might have to start a whole series of these, because when I started writing the talk, I realised that I had a lot of different issues with these patients that could fill multiple lectures. So I promise not to talk too long, and I will skip through some of it to get to the end if we are running out of time. I was initially going to talk about plastics and cataracts, but as I say, found I had quite a collection, so I'm just going to talk about my unhappy 6/6 cataract patients. And it's not about refraction, it's about everything apart from refraction, really. So Mr. JB is the first guy, and he's not happy. He's got really good vision. He's 6/6 unaided, routine cataract surgery, but he comes and sits in the room, he's got his eye closed. It's sore, it feels like I've got an eyelash in my eye, it's constantly irritated, it's red, it's sensitive to light. Wish I'd never had my cataract done, what's wrong with me? And he looks like this, so hopefully you can sort of see that a little bit. So anybody going to be brave and call out and say what they think might be going on post-cataract surgery to look like that? I didn't think so, so I thought I'd give you some more information. These are not him, these are just photos of similar kinds of patients. So any takers with a little bit more information about what that might be or what might have happened? What if I show you a gory picture of a needle going near an eyeball, and it should come with a warning? This is a subtenon's local anaesthetic injection. So this is what we do on some of our patients when we have cataract surgery. So we numb them usually either with eye drops and local anaesthetic that goes into the eye, and that takes away any pain and discomfort, which mainly comes from changes in pressure and touching the iris. Or we give them a local anaesthetic injection. So this is a blunt cannula. You make a little cut into the surface of the conjunctiva and you go into the subtenon space and inject the local anaesthetic. And that gives them usually pretty good, if not complete, akinesia, so their eye doesn't move, makes them completely comfortable most of the time, and it stops them from having any vision of what you're doing. Most of the time it also gets their blink, so when you put a speculum in to do the surgery, they can't feel it. The problem is that you make a cut in the conjunctiva to do this, and most of the time, as I'm sure you've seen in patients that just have trauma and get a laceration on the conjunctiva, that heals up perfectly well, but sometimes it doesn't. And so he had a persistent conjunctival defect right on the edge of his eyelid margin, so every time he was blinking, and we always give it inferiorly, so this is right sitting on the edge of his lower eyelid, and every time he blinks he gets irritation from it, it won't heal up. And I have seen patients, when it does heal, that get a pterygium-like scar or a pinguiculum-like scar in that area, so this can be a bit of a problem. It can also be something that you miss when you're looking at these patients afterwards and going, why have they got a sore eye? Because you stain them, you look at their cornea, you go, look, their cornea's clear, they haven't got any dry eye, the wounds are all healed up beautifully, the AC's quiet, they've got no inflammation. I don't know what's wrong with you, go and have some lubrication. Fortunately, most of the time, lubrication and time settles all these patients down. So apart from the issues with the subtenons, some of the other really common reasons that people get irritation post-cataract surgery just from the eye drops that we use, and I'm having done a bit of research for this talk, going to go and have a chat to some of my colleagues about this, because it's become the norm now for us to give all of our patients routinely after cataract surgery topical Predfort and topical Voltaren Ophtha 4 times a day for 4 weeks. Voltaren Ophtha is probably the most evil eye drop that there ever was. It really stings like crazy, and there's actually some pretty good evidence that it can cause persistent ocular surface pain in patients down the track. So while we might be preventing a little bit of cystoid macular edema, we may well be causing a lot more post-operative discomfort in our patients. So I think we just need to be aware of that. The good old dry eye, cover everything, ubiquitous term that just means the patient's sore and irritable. Irregular wound healing. So we do make these little cuts into the limbus. So most of us make 3 cuts into the limbus to do cataract surgery, 1 temporally, for the most part. Some people operate superiorly, but mostly temporally. And then 2 others to use our second instruments. They're all about 1 to 2 millimetres in size, so they're pretty small, and they're a stepped wound that usually heals beautifully. But I've certainly seen patients who are getting recurrent erosion type of symptoms from their wound healing, particularly if you get a little bit of a phaco burn or something on there. Blepharitis, can't forget that, but I'm not going to talk about it tonight. Eyelid malposition or eyelash malposition, persistent anterior segment inflammation. And then I've put CMO on here because what I've discovered is that quite commonly when patients come back with a bit of cystoid macular edema, they'll actually tell you that their eye feels a wee bit irritated as well as being blurred. And as soon as I see their vision's down a little bit and they say that, I'm like, all right, I need to check their macula. So I don't think CMO is necessarily completely asymptomatic, or whether that's because whatever is causing them to have the inflammation that's causing the cystoid macular edema is also making it uncomfortable. And if you've got a bit of persistent corneal edema or some other kind of problem with the cornea, obviously you're going to have post-surgery irritation. So these are the sorts of things, I mean, these are extreme examples, and fortunately most of my patients, and certainly not Mr. JB, didn't come back looking like this, but this is an eye drop reaction to the preservative in the eye drops. It can be really, really bad. You can see quite a lot of mucus discharge, and I have seen patients get some blepharons from reactions to the preservatives or reactions to the topical drops after surgery. You can also reactivate their HSV, so we're putting these patients on unopposed steroid medication, quite high doses for quite a long time. So if they don't give you that history that they've had HSV before, you can certainly give them multiple dendritic ulcers on the surface of their cornea.
If you have a patient that referred you on today, history of...
So if you know that they've had HSV and you're doing cataract surgery on them, you should put them on prophylactic oral valcyclovir in that post-operative period while they're on the topical steroids. All of them should have that really, because they don't need anything pre-op if their disease is quiescent and they haven't got any scarring or anything. I mean, I think patients valcyclovir is such a well-tolerated drug that patients who've had corneal disease from HSV and have persistent, have scarring or likely to recur, I think they should be on prophylaxis, personally, orally. The problem is that the evidence suggests that they need to be on it for life to get the benefit, or whenever they stop it, the risks of the HSV recurring come back again, so you don't get any prolonged benefit beyond the period of time that you're taking the tablet. But with valcyclovir, it's just 1 tablet a day, and it really does reduce the recurrences. So if we've got a patient who's had HSV who's got persistent disease or scarring and might be at risk, I'd put them on prophylaxis for life. If they've just had an episode of a single dendritic ulcer or it's gone away and cleared up and they've got nothing but they've got a history of it, then I'd give it to them for the length of time that I was treating them with steroid, but not any other time. The problem is the ones that don't know, they don't realise that that's what they've had. They may not have ever had it diagnosed. You do see, and I'm sure you see more than I do, patients who come in who've got this intermittent red eye that happens every now and then. It's conjunctivitis, and probably what they've had is recurrent HSV ulcers on their cornea, or at least some irritation from it. And then they present finally with it when it comes out. And so those ones may never know that they'd had it. This is a persistent inflammation, so we do see this a little bit. Most of the time, if you've still got inflammation at 4 weeks after the surgery with just a few cells in the eye, it's nothing that you need to worry about. But if you're seeing patients back and clearly they've got pain, inflammation, redness, then something's going on. They need to be restarted on their steroids if they've stopped them. And does anybody know what the key examination that we would like you to do, or that we should be doing if you've got a patient who presents? So say you've got someone that comes in 6 weeks post-cataract surgery, red sore eye, 3+ cells in their AC. Any ideas what we might be? Maybe that's a bit extreme, 2+ cells in their AC. You don't think it's an infection?
Oh, they can have retained capsule in your...
Perfect. So we're worried about a retained fragment in these patients. It's not that common, but it's the thing that can be causing a problem. And where do you find it? Since you're so clever, Sally. Part 2, where do you have to look?
Oh, so you do gonio, don't you?
Perfect.
You have to do gonio and then,
Yeah, well done. So you have to do a gonio on these patients and have a look, because sometimes you'll see that there's just a little bit of nucleus or a tiny bit of cortex or something that's trapped in the angle, and that's what's causing the persistent inflammation. And then we have to go back and suck it out. Or it depends what it is. If it's a chunky, decent bit of nucleus that's been missed, you have to go back and take it out because it will never break down. That's quite rare. I think I've seen that once or maybe twice. If it's just a little bit of cortical material, which is much more common, then you can just treat them with anti-inflammatories and it will break down. But these are the sitter patients for getting cystoid macular edema. And this is not uncommon, so this is an entropion rather than trichiasis, so the whole eyelid margin rolled in and the lashes against the eye. The trap with this is it's often intermittent, so they'll say they've got this irritation, but the lid will look perfectly normal, so you want to do something stingy, hold their lid up, get them to close it, try and bring on that entropion. See this not uncommonly, whether it's a bit of irritation from the eye drops or the preservative, or whether it's just from the cataract surgery and having the speculum in and a little bit of stretch in the eyelid, but obviously something that's going to need treating. I have had some success when these have come on immediately after cataract surgery, which is rare, by giving them some Botox injections into the lower lid, so relaxing the muscle, getting the spasm to go away and then not having it recur. So I'd certainly be trying that in these patients if it's come on because of something I've done to them. Unfortunately, most of the patients that we see with irritation after cataract surgery, or certainly the ones that come back to me, don't have any of these things wrong with them. So you look at them and you think, well, really, you don't look that bad. The eyes, your vision's good. The eye looks white, there's no inflammation, but they're actually reasonably miserable. They're complaining about this quite a bit. And if you ask them, they complain about it quite a lot. So actually, when you look at the studies on this, half of the patients have this at 1 week, which I guess most people would expect and seems reasonable. But, we tell our patients that this is a painless operation, that we're going to do surgery on them and they're going to be able to see the next day and not have any problems. I think we should be telling them this is going to be irritating and uncomfortable and it's going to take, days to settle down. And 20% of patients actually still have ongoing irritation 6 months after their cataract surgery. That's really high. I suspect that we just don't see them, and you're probably dealing with them more than we are by the time they come back in and get their glasses and things done. And so the tricky ones are the ones where there's no obvious cause. And this has a name. So there is this condition, which I didn't really realise was specifically named, called ocular surface pain syndrome. There can be some exacerbating factors that cause it, so obviously you're going to be looking out for those things like drops and preservatives, dry eye, meibomian gland dysfunction, and by dry eye I mean aqueous tear deficiency in this when I'm talking about this here. So the other thing is that cataract surgery, just like any kind of refractive laser procedure, can alter the corneal sensation. So when you do anything that cuts the corneal nerves, you reduce the tear production for a start. And what also happens if you cut these corneal nerves is that you start to generate abnormal pain responses in people. And we know now that if you have ongoing and repeated interruption of that pain those pain pathways, that you get aberrant pain responses. So it may be that these patients don't have anything wrong with their eye. It's just that because we've cut the nerve's been stimulated as it's been regrowing and they're getting abnormal stimuli that are giving them a sensation of pain. That's absolutely true, but that there isn't anything that we can see or do about it. And there's this theory now that dry eye exacerbates this because if you've got a reduction in your aqueous tear production, you're getting persistent epithelial defects, that's inducing inflammation, and that the inflammation causes irritation of the corneal nerves and then increases the chances of patients getting what we now refer to as neuropathic pain. So pain that's because the nerves have been stimulated, not because of anything that's directly going on in the eye. So this is quite an interesting condition when you look into it a little bit more. The pain sensitivity varies hugely between patients who suffer from this. There's quite a few known associations. So anyone that has chronic pain from other causes is more likely to get this ocular surface pain. It's more common in women than men. Definitely there's some link between emotional status and coping mechanisms. So if you've got a patient that's got high anxiety or having a stressful situation, then they're more likely to develop this afterwards. And that's not to say that they're making it up or they're just anxious. It's just this whole idea that the response to pain or the response to stimuli that causes pain is influenced by things beyond the pure physical. So definitely medications. There's a much higher incidence of it in those who use topical non-steroidals post-op, hence my comment earlier where perhaps we've gone a little bit too far to preventing the odd cystoid macular edema if we're going to see an increase in these sorts of problems, which are much more difficult to manage. It's higher in patients who use glaucoma drops, especially 3 or more a day. We don't see that many that are on 3 glaucoma drops now, fortunately. But also patients who are on systemic medications, which you'd think would have very little to do with the eye, and not just those that cause dry eye, and higher rates in patients who are on any kind of antidepressant. Again, not just those that, like citalopram, that causes a dry eye, any kind of antidepressant. And then just the ordinary things that might cause an irritation to the surface of the eye. So, well, that's all well and good. We've got this patient who's got a white eye and pain and they're anxious and we say, well, you've got ocular surface pain, but what are we going to do about it? There's not really any specific solution for it. So it's the same old things that you'd be doing to treat these patients anyway. Lubrication, trying to stick with preservative-free because the preservatives might be one of the exacerbating factors. Looking after their blepharitis if it exists. IPL's been used regularly for patients who've got post-cataract pain, just to try and stimulate those meibomian glands. Probably some gentle steroid to reduce that inflammation if it's going on and to help to decrease that pain cycle will be beneficial. To avoid things that might make your eye uncomfortable. Sunglasses, reassurance, and in the longer term, if this really isn't settling down, patients are ending up on medications that modify the pain response rather than things that are for their eye. So this is where amitriptyline, gabapentin or pregabalin, that tending to use more now, come in. These are pretty hefty medications that have a big impact on your life as far as their neurological side effects. So we don't want to be trying to get our patients into this situation. So fortunately, none of this was the problem for Mr. JB, who was the original unhappy patient that made me have a look at all of this. He has simply had a little bit of conjunctival dehiscence and hadn't healed up well from where we'd given him the subtenons blocks. So we gave him a bit of chloramphenicol, a few lubricating drops, sent him away and he came back in a month happy. So that's good. So next was Mrs. IP. And so Mrs. IP has got glare and she's also 6'6" and unhappy, and she came in and she said, look, my vision's great, but every time I go out and drive the car I've got to close my eye because the glare is so awful. I really can't drive at night, sensitive to light, it's watering all the time, I'm having to wear my sunglasses even inside, I really can't watch the television or even use the computer because it makes my eye ache. So... glare after cataract surgery. Now I've gone from dry eye to DED, which is dry eye disease. So this is going to be featuring in all of these post-operative unhappy people. Obviously, if you've got some kind of refractive error, you're going to get some glare, particularly if you've got some astigmatism. She didn't have any of that. Any sort of corneal problem, whether it's caused by the surgery or was there already, is going to cause glare. Glaucoma and retinal problems, pre-existing pathology, certainly causes glare. So even just having vitreomacular traction or an epiretinal membrane can be enough to give a patient glare. The intraocular lens material that we use is quite interesting. So all of them have very high refractive indices. And the idea is that you want to transmit that light. So all of them can cause glare of their own. That's supposed to say blue filters. Sorry, blue filers. Because of this, some of the manufacturers have gone to putting yellow lenses in to block out some of the blue or the UV light. Whether that actually does anything, I don't think has been proven to be any benefit as far as reducing glare. And then pupil abnormalities are obviously going to be causing some problems with glare. So Mrs. IP had routine right cataract surgery, no other ocular problems. It was an ordinary monofocal lens that she had. She used the usual post-operative regime that we now typically use of Voltaren and Predforte QDS for 4 weeks. And on examination, her vision was 6'6" unaided, and she looked like this. So to the astute observers, hopefully you can see it with the lights up at this level. It's the right eye. It's a little bit red, and And it's dilated. Sally, top of the class. Yes, absolutely. So she's got a dilated pupil. And so anything that dilates your pupil is obviously going to give glare. So what could be going on with her? Certainly she could just have an ordinary 80s pupil. So there is definitely an association with developing an 80s tonic pupil having cataract surgery. It could just simply be that she's had cataract surgery and her pupil was not constricting as well. So when you actually carefully analyse people's pupils after you've done cataract surgery on them, or other people have, not me, you certainly see that their ability to be able to constrict their pupil in the short term anyway is reduced compared to the non-operated eye. One of the things that you can see is that a post-operative intraocular pressure spike can certainly cause some ischemia of the iris, and it commonly results in a mid-dilated pupil. So we don't commonly see patients on day one anymore. Most of the, unless they're a glaucoma patient or have other risks, but potentially they could be having a spike in their pressure overnight and causing this ischemia and getting this mid-dilated pupil. In much the same way as you see patients after an angle closure episode where their pupils, dilated and not reactive. And then there's this phenomenon of the atonic pupil, where you see these patients on day one after their cataract surgery, their pupils reacting completely normally, and 2 to 4 weeks later, their pupil suddenly dilates, usually not completely, just dilates slightly, mid-dilated pupil, and it becomes non-responsive to light, non-responsive to accommodation, and non-responsive to miotics, which is really helpful. And actually the reason that this happens after cataract surgery is unknown, and it's quite common. 6 to 10% of patients in some studies develop this atonic pupil, or if you compared them to the non-operated eye, had a slightly more dilated pupil. There was some theory that could it be related to toxicity from something that we were using during cataract surgery, and one of the culprits that was targeted was hyaluronic acid. But we use this in everybody and we put loads of it in, so I don't think that's really come to fruition, but there could be something that we are using that could be causing this. And then, of course, there's surgical trauma. So floppy iris syndrome is a real problem for us when we're operating. It's increasingly common because it's caused by medications that are used much more frequently. So tamsulosin, any takers for what tamsulosin's for? Yeah, so it's for prostatic hypertrophy. So it's an alpha agonist and it interrupts pupil dilatation and the responses of the iris. So the problem we get is that patients' pupils don't dilate normally when we put our medications in before cataract surgery. The iris becomes very, very floppy and atonic. So when you're operating, if you touch the iris in a patient with floppy iris syndrome, it just completely collapses and falls out of the wound, or it just becomes a real problem. And the other issue with it is that patients who are on tamsulosin, if you stop their medication, it doesn't fix the problem. So once they've been on tamsulosin, if they get this floppy iris syndrome, you're kind of in trouble. So for patients with floppy iris syndrome or many other conditions, there's lots of reasons people's pupils don't dilate well. Just simple diabetes can affect the dilatation of the pupil. PXF obviously is going to stop their pupil dilating. Age definitely has a factor and stops it dilating, previous inflammation, loads of reasons. But in these floppy iris patients in particular, we use some kind of device to kind of control the pupil and to try and hold the iris in place. So this is the most commonly used device, and I didn't want to put too many gory pictures up, so this is just a graphic, obviously. But if you've got a patient who's got a small pupil, you need that pupil larger to be able to do the surgery. So it comes in a little injector. It's made of polypropylene, and it has these 4 little loops on it. And so as you inject it, you put the loop underneath the iris and on top of the iris, and it captures the iris, and then as it dilates, it gives you a nice, well-controlled pupil, and it helps to keep the iris in the same plane so that when you're doing the cataract surgery, it's a little bit further back and out of your way. So it's pretty clever. Unfortunately, all of the devices that we use to dilate the pupil also cause some damage to the sphincter. So when you're putting these in, even though it's really gentle, the pupil's been constricted for a reason, and when you mechanically dilate it, you damage some of those sphincter fibres. So these patients often end up with a pupil that's not as reactive, a little bit dilated, a little bit irregular, and not the same as it was beforehand. So you just need to be aware of that. These rings seem to be much better than iris hooks, which is what we used in the past. And some people still use iris hooks. I don't have a picture of those, but they're little polypropylene devices that you put in. They're individual devices, and they have literally a hook on the end, and you put them in through a wound at the limbus, pop them over the edge of the iris, hook them on, and then they have a little thing on them that you advance, and it tightens up as you advance it, so it gives you a bit more control over the size of the pupil. The problem with them is that they work from the wound, so they pull the iris up. So when you're operating, these are still in the iris plane, but when you put hooks in, they pull the iris up towards your wound. So when you're then trying to put your instruments into the eye, you're really close to the iris. And when you touch the iris, you do this sort of thing to it. So it's minimal iris trauma that causes these kind of transillumination defects after the surgery. So, you know, I look at my patients sometimes and think, oh my God, look at the iris. And literally that will have been one touch with one instrument that's been enough to cause that kind of problem. So it's pretty tricky, got to stay away from the iris. So that's why we love these myopes with their big eyes and their massively dilated pupils. So what are you going to do about these patients with glare? And we're going to reassure them that lots of the time it gets better, and if we just wait, they'll get used to it and adapt. We're going to treat the underlying cause if we possibly can. So we're going to use our preservative-free lubricants, reduce or change their glaucoma drops, correct any refractive error, any AC inflammation, and then all those glare reducing things. So sunglasses, hat, glare protection on computers. And then you get into the controversial blue blocking tinted polarized lenses. I tell them all, any of these things might help you, have a go. I'm not sure that there's a lot of evidence to suggest that they necessarily do that. I mean, blue blocking lenses are designed obviously to reduce blue light, not all light. Same thing with polarized lenses and any kind of coloured lens. So they're going to certainly decrease the amount of light getting into the eye. So they all help. And then there's brimonidine. So brimonidine is quite a useful drop for us in this situation. It's a selected alpha-2 agonist, so it seems to have fewer side effects than most of the other myotics. It reduces the redness in the eye, which is quite good. And, oh, another mistake. And in scotopic conditions, it inhibits the pupil dilatation. So it can help patients, particularly if they're noticing problems in duller light. It's not so good in bright light. It doesn't seem to have quite the effect in bright light. But it's worth it because other agents that dilate that constrict the pupil, such as pilocarpine, are really pretty miserable. So lots of the younger optometrists in the audience have probably never even used pilocarpine to treat glaucoma. It's a pretty ugly drug for treating glaucoma, but I suspect there might be one, John, who would have been around in the days that pilocarpine was just about the only drug that there was to treat glaucoma. And the patient's a pretty miserable drug, don't you think? Yeah, so it gives lots of headache, lots of systemic symptoms. Patients really don't like it. Profuse tearing, it can have lots and lots of systemic side effects. So even if you give it to patients, it's quite effective at constricting their pupil, so it's good from that point of view, but I don't suspect that there's many patients that are going to continue to use pilocarpine long term just to make their pupil smaller. So if none of that works and you've got a patient who's got a problem with their pupil, there are surgical things that you can do. I don't really do them, which is why I had to steal poor photos from the internet to give you examples. But this is a patient who's got a dilated pupil following cataract surgery. And this is a patient, what they've gone on to do to this patient is put a suture in. So that you can see here that this has been pulled together, and this is basically just a suture that's been put through the iris to just constrict the pupil down. What do you think the problem with doing this is? Any ideas? Yeah, exactly. Then you've got a fixed small pupil. And so that's not so good when you want your pupil to dilate to be able to improve your acuity in dull light. So it's also technically quite difficult to do. They do extrude, they do cause iris chafing, so they can cause a bit of pigment dispersion, glaucoma, lots of other things. So you want to know that the patient's really badly suffering from it before you go and do that. If you've got a patient who's ended up like this following cataract surgery, so again, not my patient, just stolen from the internet. But clearly this patient's going to have problems with glare and they're going to be pretty unhappy with their vision after cataract surgery, and there's not any suture option or anything reconstructive that you can really do to fix this situation. There's not much iris tissue left there. So that's where you have to go and do things like put these Morse ring segments in. So these are pretty cool. They just slide into the eye in much the same way as we put intraocular lenses in when we do cataract surgery. So we make a little wee cut at the limbus again, and you inject them. This one comes fixed, sorry, so you pop it in, you put it in the bag, and you literally rotate it into the bag, and it sits underneath the iris and just blocks out the light. So they're pretty effective, they're very well tolerated, and because you can put them in the bag where the intraocular lens is, they don't tend to cause a lot of problems with inflammation after surgery. So cosmetically they can look really quite good. So this patient's had one put in already, so there's one segment already under here that you can see. So you can see there's definitely an improvement, and certainly they really help with glare. They come in segments, or they can come as an entire iris, and you can get complete iris implants that are all coloured and pigmented and look just like an iris. You can even get them colour matched to the patient. So if you've had a patient who's totally lost their iris in trauma, or someone who's got aniridia and no iris tissue, you can actually completely replace their iris with a fixed, pigmented, coloured to match iris. So that's pretty cool. So fortunately for me, in this situation of this lovely lady, I gave her some lubricant and sent her away, and she was a little bit better but not happy. I gave her some bromonidine for a little while, and by the time I'd sort of seen her back and listened to her concerns for 3 or 4 visits, she seemed to have settled down enough and got used to it, and I couldn't find anything much wrong with her. So she went away reasonably happy at the end, I think. So next is Miss CL. So she's a young hypermetropic patient. So her spherical equivalent was about +3.5 right and left. And she developed a unilateral traumatic cataract. So vision plummeted with this posterior subcapsular cataract. She's retained vision of 6.5 in her right eye, but dropped down to 6.60 in her left eye. So she was in her late 40s, still had some accommodation. So I had to discuss quite a few things with her before her cataract surgery, which were going to be a problem. So obviously she's going to end up with quite significant anisometropia. I don't really want to leave her hypermetropic after her cataract surgery. Her hypermetropic outcome's not desirable really, especially not 3.5 diopters of it, I don't think. Don't know if anyone, you can feel free to disagree, matching them at the end, but I don't think hypermetropia is much good for anybody. Had to discuss about the loss of her accommodation, because at this stage she still has enough accommodation that she's managing, so I'm going to go and fix her eye, but she's not going to have any. I mean, at the moment she's managing, she's got one eye that hasn't got a cataract that can accommodate a little bit. Had to discuss the possibility that even though there was nothing wrong with her other eye and she had really good vision, we might have to go and do the same kind of surgery to that eye. And in the end, after all those discussions, we decided that we'd aim for emmetropia and that we'd put a monofocal intraocular lens in. So I went and did her surgery, and she's delighted with her vision after her cataract surgery. So she's 6.5 unaided in the eye that I've operated on, and she's 6.60 unaided, of course, because she's still +3.5, in the eye I haven't operated on. And she's really comfortable, and she tells me she's happy that she's just going to go and have her glasses changed and she's going to manage as she is with her 2 eyes. We'll see whether that is true. But what she's not happy about is the colour that she can see. So she tells me that when she's looking out of her new eye, everything looks cold. Her couch, which is brand new and was bought just before her cataract surgery, which was a beautiful creamy colour, is now white and cold looking, and she doesn't even want to sit in it. These are the sorts of things she's telling me. Her clothes all have a slightly purple tinge to them, particularly anything that's navy blue or dark. And when she closes the eye that I've operated on, even without her glasses on, when everything's a blur, everything looks normal again and is all the right colour. So what the heck have I done to her? She's like, my eye's still the same colour. So I said, yes, don't do that when we do your surgery. It's got nothing to do with that. So I'm sure you've seen patients who tell you that the colour that they're seeing after their cataract surgery is different. And in patients, as the lens gets nuclear sclerosis, it starts to go yellow. And of course, the yellow lens is blocking out the blue light. So when you remove the yellow lens and you put an artificial intraocular lens into the eye, you're increasing the spectrum of light that enters the eye at that blue end of the spectrum. But, you know, this is comparing a clear lens in a patient with, yes, one that had a cataract, but it's quite a stark difference. And this really happens with some of the intraocular lenses. So without mentioning any names, and like I use all of them, but some of the lenses definitely transmit much more of the UV end of the spectrum. And those patients, in the older patients, when you put them in, they all come in and talk about the Arkarot crockery. You know, that brown Arkarot crockery? And they all come in and go, that's purple. You know, so that's what happens with these lenses. So they transmit too much of the UV light, or more of the UV light than the natural lens blocks out. So lots of patients, when we take their lenses out, as I say that everything looks vivid and bright, and some of them will say it looks whitewashed, but this true change in perception of colour can happen with some of these lenses. So in the end, after a lot of discussion over many visits about what we were going to do, we actually decided to do a clear lens extraction effectively in her other eye, and I used an Alcon yellow tinted lens in her other eye, and fortunately, the surgery was all routine and her vision was excellent afterwards. And now when she looks through her yellow eye, as she calls it, everything is the right colour and her couch looks beautiful and she's happy. And when she's got both eyes open, everything is okay. As soon as she closes her good eye, as she calls it, and uses her bad eye, that was 660, corrected with a posterior subcapsular cataract, everything looks that horrible cold colour again. I did offer to exchange her intraocular lens with the usual caveats that that's an incredibly difficult operation to do and we might not be able to get the lens back in the same place, and all of those sort of, I could do this if you really want me to, but you know, maybe you're better off with the lens you've got. She decided to leave it be. But it's just these sorts of patients that make me realise that in our informed consent process there's a lot more discussion that, you know, perhaps we need to be having about what they might see afterwards, and some of these perceptions of good vision are not the same for our patients as what we sort of expect them to be having. And I say here the opposite issue with Mrs. Painter, because I was saying to one of my colleagues in Wellington, you know, about this patient when I was asking everyone what they thought I should do with her cold eye and her couch that she wanted me to replace and all these other things. And they said, well, I've got the opposite. I've got a patient who actually works doing test colour painting and giving people advice about colours and in decoration and interior design and things, and they deliberately chose to have a cool lens put in one eye and a yellow lens put in the other eye so that they would have an enhanced spectrum of colour appreciation. So when they were out seeing patients who said that they really liked black, white on their walls and this cool kind of colour scheme, they could cover up this eye and give them advice about which colours and things they should have with a, you know, true appreciation of what that looked like for them. And when they had people who liked beige and neutrals and warm colours, they could cover the other eye and do the same thing. So there you are. So while this is not actually a dysphotopsia, it's sort of similar to a dysphotopsia, and really the most common reason that patients come back and see me and are dissatisfied, even though they're happy, if that makes sense, is because of their dysphotopsias. And 67% of patients, if you ask them about it, notice this in the first week after surgery, and even at 12 months, at least 2% of people are still having these. So they're positive and negative dysphotopsias. Positive dysphotopsias are glare, flashes, halos, arcs, light streaks, so anything that's bright or positive in colour. And I'm sure you spend a lot of time looking at retinas to reassure people they haven't got a retinal detachment, and explaining to them about these positive dysphotopsias that they're getting. The halos really usually come from multifocal lenses and are uncommon in other types of lenses, but the rest of them you see in perfect cataract surgery, in routine, normal standard eyes, really quite commonly. So we don't exactly know why patients get these dysphotopsias. The we blame the lens manufacturers and tell them that their lenses are causing it. Definitely the type of material seems to be at least partially indicated. So the higher the refractive index of the material you're putting in the eye, the more likely it is that they get these positive dysphotopsias. The edge of the optic certainly seems to have something to do with it. So most of the lenses that we implant now have a square edge, and the point behind that is it's supposed to decrease the rates of getting posterior capsule opacification. But because of that sharp edge, you probably get more of this edge effect with the light passing into the eye, giving the dysphotopsias. Pupil size is probably related. Most patients complain more of this in mesopic light, but I certainly see patients who notice it bright light, dull light, all the time. And yeah, if you've got a larger pupil, perhaps that might cause more of these dysphotopsias. Certainly it causes more glare. Often these patients notice it and just want some reassurance that it's fine and okay and it's something they can live with, and when you ask them about it down the track, they really don't notice it anymore, or certainly not enough to complain about it. But there are the odd patient that really is quite bothered and persistently complains about it or comments to you about it. So there's various different types of lenses that we use and put in the eye. The manufacturers have chosen various different colours to use to try and reduce some of these effects of dysphotopsias, but I think they all do it. So I don't think it matters which design of lens you put in or which type of lens. Some of them will do it much more than others. So the lenses that tend to make everything go purple also have a slightly smaller diameter. So some of the lenses have a 5.5mm optic and some of them have a 6mm optic. So the lenses with the 5.5mm optics definitely cause this a little bit more than the slightly larger ones. And it probably has a little bit to do with surgical technique as well. And I'll show you a picture in a moment. Negative dysphotopsias are the opposite. So these are the arc-shaped shadows or a line in their peripheral vision. Obviously, we need to exclude any kind of retinal problem or a neurological issue that could be causing this, but we really never find one. It's a very typical description, usually in bright light, and it persists again in about 1 to 3% of patients. Even years after cataract surgery, they'll notice it. And some of them really are bothered by it, you know. They really say, feel like I'm walking into a room and I can't see out to the side. And again, I'm sure you see this all the time, that they're coming in and saying to you about it. Again, we don't really know why. Probably some of the same kinds of reasons as the positive dysphotopsias. But really the theory is about this gap theory. And so I put up a photograph of an intraocular lens inside the eye with a dilated pupil, just so you can kind of understand what I think they're talking about here. And the idea is that when the light passes in through the optic of the lens, that's giving an image on the retina that the patients are interpreting. When it hits the haptic, it's also getting some kind of image that the patients are seeing, but in the space between the two, there's literally a gap. So if the light's going in and hitting that gap in between, that's where the patients are getting either the positive effect from the edge of the lens or a negative effect from seeing nothing. So simplistically, that's the kind of theory behind it. They do say that if you do this technique during cataract surgery called IOL capture, that decreases the rates of having it, but it increases the rates of other problems, so it's not something that we routinely do. But the idea behind that is when you do cataract surgery, you make a hole in the front. Has everyone seen cataract surgery? Has everyone been to theatre and seen what happens? Yeah. So you make a hole in the front part. The cataract is like a pebble or an M&M lolly, so you make a hole in the front part of the candy shell and take that away. You suck out the chocolate and you put the new lens in through the hole and it opens up inside the capsule. So the lenses have C-shaped haptics on them and they open further or less depending on how big the eye and the bag is. So once those lenses are open and the light's passing through, that's where you get the gap. So you can do this IOL capture where you leave the IOL outside of the shell. So the haptics are inside, but the lens is on the top of the hole that you've made in the front part of the shell. And the effect of having the anterior capsule behind the lens seems to block out these dysphotopsias. The problem is then your lens is really close to your iris, and so when your pupil's constricting and dilating, you get more iris chafing, more problems with transillumination, post-op inflammation, glaucoma, rah-de-rah-de-rah-de-rah. So probably not worth it for the dysphotopsias that usually require a bit of information, but nothing more than that. And really there's nothing you can do. You can do all of the things that you would do anyway to try and treat the eye, but nothing that you can do to really make them go away. A bit like doing the IOL capture, if you have had complicated cataract surgery and your shell is broken and you can't use that bag to put the lens in and you put the lens in the sulcus, those patients don't seem to get it. So it's obviously something about the position of the lens in the eye when it's that little bit more anterior, or having the capsule behind it that acts as a block that stops this from happening. So I knew I'd talk for too long, so I'm actually going to flip through Mrs. CM. I'll save her for another day. Which is a bit of a shame because it's where my little quizzy questions are. Well, actually, you've got a choice. Okay, you guys can decide. I can either do, because we've got about 10 more minutes, I can either do the last case, which is another patient who's not happy, which is a bit about fusion and dominance and amblyopia and that kind of thing, or I can talk about complaints and HDC and writing a complaints process. Yes, okay, perfect. She's still not happy. You have to tell me what the most common reason that patients complain is. Any takers? What if I give you 5 options? I'll see if I can remember all the things that are on my slide. So the most common reason patients complain, because they're unhappy with their outcome, because you haven't communicated to them properly, because they've had to wait too long, because they felt like they weren't respected and you didn't listen to them, or something else which I can't remember. The bill. The bill? Yeah, not many complain about the bill. We usually send those ones to Simon. Yeah, okay, the bill. That's the ones that complain to you, the most of the ones that complain about the bill. Okay, and you must be good at all the rest of it. Communication. Yeah, absolutely. So complaints is really all about communication. And I don't mean to, with what I'm going to present here, I'm not at all trying to suggest that people don't communicate, and it's really just from my own perspective. Really, complaints are all about communication. So you can have the worst outcome in the world and you can spend a lot of time with that patient and they'll be really happy. When I was a registrar and I did one of my first operating lists on my own, I was doing cataract surgery and I had a patient that in the middle of the cataract surgery, for some unknown reason, she sat bolt upright while I was in the middle of phacoing. So you can imagine this didn't quite go very well. In fact, it was a complete disaster and there was like lens at the back of the eye and it was a shambles, and she ended up having to have a vitrectomy and all these things. And in the end, she ended up with quite good vision. But through all this, she had multiple visits back to the eye clinic, and she used to sit in the waiting room and say to all the patients, I sat up during my cataract surgery and it was really bad, but it's all going well now. And like she was, in the end, like wrote this letter and said, you know, how happy she was with her outcome and things. Probably helped by the fact that it was good in the end, and she had some insight into the fact that she had sort of contributed to this problem that had developed. But I just guess it's the fact that you can see these patients, and when you see them all the time and form a relationship with them, even if they have really bad outcomes, which unfortunately some of these patients do, they can actually still be happy with the service that they've received and understand what's going on. So it's not those patients that complain. It's the patient that you see that's got nothing wrong with them, that you do their cataract surgery and they're literally 6'5" and their eyes not red or sore or anything, and you get them back in and you go, aren't you great, goodbye, thank you very much. And they go, well, that felt very rushed, and you know, I didn't have enough time with the doctor, and you know, they didn't tell me this, this and this. So basically, first of all, the best thing is to try and prevent getting these complaints in the first place. So unfortunately, it often means sitting down and listening to the concerns even when you feel like they are completely invalid. Taking time to explain carefully to patients so they understand what's wrong, what you might be able to do to help, why this has happened. I should have added in here, be honest, because I think being honest and authentic really goes a huge long way to patients understanding. So this particularly applies when there's been a problem or a mistake. If you say, look, this has gone wrong, this is what's happened, this is why, this is what we're going to do to fix it, they're usually pretty understanding of that. Apologising is really important. So if something's happened, like you can say, I'm sorry you're feeling like that, or I'm sorry that this has happened to you. It's not an admission of guilt. It doesn't mean you've done anything wrong. It's just an acknowledgement of the fact that they are upset and that something has happened that hasn't been an ideal outcome. And it goes a long way to helping them to understand that, yes, something hasn't gone the way that they wanted it to, but that you understand that and that you have some empathy for the situation that they're in at the moment. I think it's really important to keep on seeing the patient. So sometimes these are the patients that you just want to get rid of and you never want to see them again. But continuing to try and work on that relationship, if it's redeemable and if they're being reasonable, is certainly important. And you have to try and get to the bottom of their concerns. Having said that, it's also really valuable to offer a second opinion where that's possible. So if you feel like the trust is broken down or the relationship's broken down, you can say, look, I don't know what's wrong, or we're not getting to the bottom of your concerns, and clearly we haven't fixed everything here. I think it would be a really good idea if we got somebody else to take a look, because a fresh set of eyes can offer a new perspective and they might be able to find what's wrong. And people really do value that when you say, look, I don't know, but somebody else might not. So don't feel that means you haven't done a good job or that you haven't fixed them, but it's really useful for both sides. I think you have to be really clear about the ongoing financial expectations, and I'm sure you have this situation as well. Like you see a patient and you make them some glasses and you see them and they're fine, and then 6 months later they come back in and they go, well, these glasses aren't right, and something's wrong. And there needs to be some clear discussion over what that means and what's going to happen and who's going to pay for it. Because I think if you tell them there's a cost involved in this and it's a reasonable thing, that they're going to cope with that. But if you sort of start doing things, and this might apply more to us than you, but if we start organising tests or doing things on them that cost a lot of money, and we haven't said the ongoing part of this is going to involve a cost and this is what it will be, that's when they get annoyed. If you say, well, in order to get to the bottom of your problem, I need to do a few more tests on you, and these tests are going to cost you this amount of money, or let's go halves or whatever, but just being upfront about it's really important. And I can't emphasise this enough, be extremely careful with your documentation all the time. So even when you have got a perfectly nice patient, write it down. If you haven't written it down, it didn't happen. And I think we're in an increasingly problematic environment as far as expectations from people. Their opportunities to make a complaint and where they can go to make a complaint is massive. And it really all is going to come back down to, if you didn't write it down, it didn't happen. So be careful with your documentation. So over and above everything else, the most common reason that patients complain, and this is out of the medical journal, the HDC reports, anything you look up, it's about communication. They didn't tell me this, they told me this, it wasn't true. Anything to do with communication. They didn't respect me, they didn't inform me about X, Y, and Z. Incorrect, missed or delayed diagnosis follows along with delayed treatment. And it's interesting that it's these delays that people tend to be more concerned about than actually the outcome. So again, even if you've got a bad outcome, if someone's got cancer and you have to tell them that, unfortunately, obviously not you guys, but if it's for us, it's not that they're upset about. It's the fact that they knew something was wrong and they hadn't been seen for 6 months, or you said you were going to do something but you didn't do it in the time that you promised. Post-surgery complications feature up there, inappropriate conduct or behaviour of the doctor, lack of respect for the patient, breach of confidentiality, and long wait times. So I was going to talk just a little bit about the complaints policy. So all of you, whether you're whatever kind of practice you're in and whatever your situation is, whether you're locuming or students or working or owners, there has to be a complaints policy. So you're required to have a complaints policy. And it should be in place to make sure that you deal with patients in a manner that's reasonable, straightforward and speedy. I think it's important to remember that complaints offer constructive criticism and suggestions, and they're valuable for improving standards of care. So they're not something that we want to encourage, but they're certainly something that we should take on board in a positive way and say, what can we take from this to get a better outcome? Not something that we should take personally and be defensive about, although that's very hard. So it's all about making sure that we're taking the patient's views into account and that we are seeking to put the patients first. So it is absolutely the right of every healthcare service user to bring aspects of their treatment and care that they're dissatisfied with to the attention of the service, and they're entitled to have their concerns investigated, to receive a full, prompt, open and honest explanation, as well as an apology if required. And this is all based on an Act of Parliament, and it applies to all healthcare professionals. So I'm going to give you some more specifics in a minute. So where might patients be able to make a complaint? So they can obviously come into your room and complain to you. They can go outside and complain to the receptionist or the practice manager, and they can do that by telephone, on an email, in person, or they can write it down and send you a letter. They can go to the practice or the practice manager. I'm sure they can probably go to the company. So I'm sure Specsavers have some kind of thing where people can just go onto the Specsavers website and fire off. Well, and I'm sure if they don't, that there'll be some kind of email address that someone will be able to get hold of on the internet where they can send that off and do it. They can complain to your regulator, they can complain to the HDC, and they can complain to a local politician. That's probably the best one, because it probably doesn't really involve too much. It's unlikely to lead to anything. So as a part of looking into this, I looked up the ODOB's website to see what their policy on complaints was, and this is fascinating. Has anyone looked at this? Do you know what it says? Oh, that's brilliant. So the ODOB policy on complaints is all about making a complaint about ODOB. So there's actually nothing on the ODOB website that says anything about making a complaint about an optometrist, or a dispensing optician. Which, well, sort of good and sort of not good. Interestingly, there was a review done, which I came across on the internet. It's just freely available. And it was done something to do with the Ministry of Health, because it's got Ministry of Health stuff all over it. And this was an audit that was done of ODOB, looking at the standards and basically all the processes and everything that are currently in there, and then produced a whole host of recommendations of what should be done next. And what I was interested in was this particular one. There's lots of things on here. I'm going to make that go away. And basically, the board's website has a complaint section. So I'm looking in this bit under reviewers' comment here. So the board's website has a complaint section. Do you have a complaint about an optometrist or dispensing or optician? It states that the board doesn't have the authority to investigate consumer complaints, that you should go to the dispensing optician, or even better, contact the Health and Disability Commissioner. I don't know if any of you have ever had a complaint laid against you by the Health and Disability Commissioner, but it's quite a terrifying thing when this email arrives, and it's a very rigorous process, so it's quite scary that that's sort of out there saying this is what we should do. And the recommendation was that the wording on the website needed to be reviewed, that a complaints policy needed to focus on the professions involved, and it needed to ensure that there was a framework for collecting these complaints. And there was a timeline on it, but that doesn't seem to have yet been enacted. And there were a number of recommendations on there. So the Health and Disability Commissioner really is the overarching responsibility for investigating complaints about all aspects of the health sector. And it really comes out of the Code of Health and Disability and Service Consumers' Right, which is referred to as the Code. So this applies to any person who provides a health or disability service, and it can only look at matters about a health or disability service. So it does include quite a range of things, including complementary medicine, cosmetic things, as well as hospital services, but anything to do with health and wellbeing. So it doesn't look into anything to do with ACC, privacy, nothing to do with fees. So if that is who patients are complaining about, you don't have to direct them to the HDC, and nothing to do with anything that's before the legal system. So under the code, as we refer to it as, every consumer has rights and every provider is subject to the duties in the code. So every provider has to take actions to inform consumers of their rights. So you're supposed to have displayed somewhere what patients can do and if they want to make a complaint about the service that you've provided, or offer some constructive feedback about the service that you've provided. And there are a number of rights, and really the specific one we're talking about here is the right to complain. So every consumer has the right to complain about a provider in any form appropriate to the consumer. So the rights with this are all very much in favour of the person whose service, who you've been giving the service to. And so every provider must have a complaints procedure, and what you are supposed to be doing is acknowledging a complaint that's been received within 5 working days, unless it's been resolved prior to that. You're supposed to inform the consumer of any relevant process that you're then going to take to investigate the complaint. You're also supposed to let them know about the ability that they have to be able to get an independent advocate through the Health and Disability Commissioner, or that they can directly complain to the Health and Disability Commissioner. So you're supposed to have this displayed somewhere in your practice for patients with information about how they can do that. This is what the law says. And it goes on. There are pages and pages. You can go to the HDC website and look it all up, but there are pages and pages of your responsibility, what you should do, how you're supposed to display it, how patients can then access this information. And it does give you some good guidelines about what you should have. The thing that they're really pushing for now, or seems to be quite a focus of the Health and Disability Commissioner, and maybe because of the increasing number of complaints that they're receiving, is about their advocacy service. So their advocacy service is free to anybody. So if you have a patient that wants to seek some further advice, you can send them to the advocacy service. You just go onto their website and you go talk to advocacy services. It's a free service, so they can go in there and get this advocate. In my recent experience of 2 of these, the advocate has told them that they should complain about the service that they received. So the advocate really didn't do a lot to try and resolve the issues that the patients had in these particular situations. They just led to an investigation. But it's there. It's quite useful to be able to tell someone if they are really fired up that this is something that they can access in somewhere that they can get some help and some support from, but just be a bit wary of what the outcome of it all might be. Not going to go into any detail, and this is from quite a long time ago, so it was 2014 that the case was there, and 2018 by the time it was finally presented in there. But just to point out, in case you weren't aware, that patients can complain to the HDC about all of us, and this was probably perfectly reasonable. This was a patient looking into the case because I was reading it with interest. This was a patient who an optometrist had seen and very poorly documented the investigation. It was a patient that was brought in by the parent with concern about not being able to see in the right eye. The vision was recorded at 660 or something poor in the right eye and normal in the other eye. The refraction was about +1 in each eye and the same, and then they decided it was amblyopia that was the cause of the reduced vision, but they didn't really have any reason for that, and I don't think that was even written in the notes. And unfortunately the child ended up having a craniopharyngioma, a brain tumour that progressed and went blind. So it seems a very reasonable thing to look into why this happened and sort of work out something better. So really I'm well over time, and so I'm going to stop, but I guess it's just to say that unfortunately, despite our best efforts, and even though we all want to look after our patients really well, we will never make everybody happy, and there will always be patients who are disgruntled for some reason with the service that we've provided, whether that's outcome-based or personality-based. And we just have to all be prepared for that. And I think we're going to see an increasing number of complaints received. So we do need to make sure that there's some process in place for being able to respond to these, to do it in a timely fashion and to try and diffuse the situation. Because a formal complaint that goes to the HDC is a huge amount of work for everybody. So if we can avoid that happening, that's a really good thing. And so because I like cheesy jokes, and you've probably already heard this many times before, but I thought that was quite clever. All right, has anybody got any questions for me, or are you all needing some fresh air because it's so hot in here? Stunned. Terrified, no. Look, hopefully it never happens, but it's just useful to know that we should have something in there. Cool. No questions? Oh, that's all right.